All right. Well, thank you all for joining me today for a discussion of what's titled Implementing a Brain Health Plan, Evidence and Strategies for Implementation. And really, what we're talking about here today is the evidence behind the various recommendations that we make for non-pharmacologic interventions for uh, hopefully preventing, if nothing else, at least delaying onset of symptoms of cognitive impairment. The things that I would hope that you take away from today is to be able to describe at least two non-pharmacologic factors that can help delay or slow progression of cognitive decline, identify the most cognitively detrimental medications that may impact cognition, and also formulate a plan to address this during a clinic visit. That latter being probably the most important is that, it's one thing to know how to conduct a brain health plan. It's another thing to be able to find the time to fit it into our busy clinic schedules. And so hopefully we'll give some strategies here today to do so. So first up, some definitions. What is a brain health plan? Well, as physicians, we frequently get caught up with dealing with problems pharmacologically. Unfortunately, what we know is that the pharmacologic benefits of drugs for cognitive impairments are minimal, both with the older agents such as donepezil and memantine and with the more novel monoclonal antibody therapies. They have promise for benefit, but their benefit is small in the literature. But while we study it less, the evidence in the literature does suggest that non-pharmacologic interventions may actually have much stronger benefits than the pharmacologic agents for preventing dementia, as well as slowing progression of cognitive decline. And so that's really what we want to hope that we can focus on when we're talking with patients in front of us is how can we do what we can to protect and to preserve cognitive function. And unfortunately, it's not as simple as take a pill. But if we can spend some time educating on these non-pharmacologic interventions, we're probably going to be doing our patient a much greater service than just giving them a pill and saying, come back in 3 months. And a brain health plan is a comprehensive approach to reviewing these interventions with the patients. The things that we'll be discussing, we'll focus on these five: reviewing and addressing physical health concerns, reviewing medications for polypharmacy and cognitively detrimental side effects, focusing on increasing physical activity, increasing mental activity, and increasing socialization. First up, physical health. One of the big things that we know is that there's this tight connection between the mind and the body. And as we age, we have a higher risk of developing more and more physical health problems. And with increased physical health problems, often comes a reduction in functional abilities. And that's something that's important because more and more we're realizing that a loss of function alone is an independent risk factor for developing cognitive impairment. So because of this correlation, the hope is if we can improve physical health, we can improve functional ability. And if we improve functional ability, we thereby help lessen cognitive issues, or at least help people function better, even if they do have cognitive issues. Some diseases, such as strokes, high cholesterol, hypertension, can harm the blood vessels of our brain. And even dementia, we see, can harm the blood vessels of our brain. In Alzheimer's disease, you can get amyloid plaque depositing in the blood vessels of our brain that can increase the risk of reducing that blood-brain barrier, making it less effective. And when that couples with vascular disease risks, that can have a significant impact on our brain and our cognition, reducing the health of our brain tissue, even independent of dementia. Additionally, we know that focusing on one's physical health can also help address things that may be confounders in cognitive impairment, vision and hearing being major ones. How often do we get told, hey, I just told you that 5 minutes ago, but we don't remember because we weren't listening or we didn't pay attention, or maybe we just can't hear it in the first place. And if we can identify hearing impairment and correct that, maybe they patient would remember that thing that was told to them 5 minutes ago. You know, rapid forgetting from cognitive impairment can often look the same as rapid impairment or rapid forgetting from just not hearing things correctly, or misinterpreting visual cues with reduced vision. So focusing on these low-hanging fruit from a physical health standpoint can have significant impact on the performance of our mind. And one of the big ways that we can really help with this from a physical health standpoint is doing a thorough medication review. Really, what we're focusing on is this thing called polypharmacy, too many medications. It's a subcategory of bigger constellation of symptom or syndromes called suboptimal prescribing. And suboptimal prescribing is used to define different ways in which we can inappropriately prescribe for anyone, but most importantly, in this case, for the older adult. Really, there are four categories of suboptimal prescribing. There's polypharmacy, which is giving too many medications, underutilization of medications, not giving meds when we need to, you know, for instance, in ignoring or under-treating pain. Inappropriate prescribing, which is using non-senior friendly agents or agents that have drug-drug interactions, or adding medications to treat the side effect of other medications that we've already started, or giving the incorrect dose of a medication. For that latter part, a general rule of thumb for the older adult is with almost everything that we're prescribing, take the starting dose and cut it in half, and you're probably not going to be wrong to do that. Because what we find is that the older adult has a higher risk of side effects from medication. So even if they may need a normal starting dose of a medication, starting it at a little bit of a lower dose to begin with can help lessen the risk of side effects. And then as long as we see they're tolerating, then increasing can help get them to that optimal dose without harm. And that's really what the goal of polypharmacy and suboptimal prescribing management is doing what we can to reduce potential of harm from medications. The issue that comes up when I talk to patients in clinic about this is I get this quote, you know, I've taken this medication for 20 years and never had a problem, so why should I stop it now? Well, the thing I usually tell them is that 20 years ago, you had a very different liver and a very different kidney than you do now. As we age, every organ system in our body ages along with us. And if we treat an older adult in the same way we treat a 40-year-old, because of these various aging changes on our organs, we could wind up doing more harm than good with the medications. A general rule of thumb is that we will often hear people say that the older adult is as physiologically different from a middle-aged adult as an infant is from a middle-aged adult. And it's pretty true. Let's talk about ways in which we can think about this. And really one way that we can think about it is through this thing called the Beers list. And the Beers list is this long list of medications that are potentially inappropriate for the older adults. And they factor this in by looking at the ways in which our organs change as we age that may affect clearance of drugs or even absorption of drugs, as well as various known drug-drug interactions to see what drugs commonly get patients who are older into risk of harm. And so the Beers list lists them all out. The problem with it is that you've probably been squinting your eyes trying to read this. This is just the first 2 pages of the AGS pocket card outlining all of the medications in the Beers list, the actual list being enormous. And so the problem becomes with the Beers list, how do we adapt it in clinical practice to actually help our patients that are in front of us? Because we don't have time to sit here and read through this 6-point font trying to figure out what is potentially inappropriate, what isn't. So when we're thinking about polypharmacy, one thing I often say is focus on what's most important in that visit when we're thinking about polypharmacy reduction. And with this being a talk on cognition, focusing on potentially cognitively inappropriate medications is often the best place to start when we're talking about polypharmacy reduction for somebody who's concerned about their brain health. And a more streamlined way to think about cognitively detrimental meds is rather than just read through the Beers list, to go for something called the anticholinergic burden index. There are a lot of drugs that block the action of acetylcholine. And we know that acetylcholine is how the neurons in our brain that are involved in the hippocampus and involved in memory operate. They use acetylcholine as their neurotransmitter. And as dementia sets in, is Alzheimer's dementia in particular, what we find is that those neurons stop working because a lot of them are dying. And so anything that blocks acetylcholine is going to potentially block those remaining neurons in the hippocampus from functioning. And so we can see cognitive side effects. The classic one is up in the top left there, the antihistamines, something like Benadryl. Benadryl is a very classic anticholinergic medication. And, any of us can experience this anticholinergic effect. If you've ever taken a Benadryl for sleep one night, most likely the next day you're a little bit more fatigued than usual. Maybe you're having a little bit more trouble focusing on work the next day. It can happen to all of us, but if our brain is already impaired, those effects can be exacerbated. And so what we can find is that a single dose of Benadryl in the older adult with cognitive impairment can actually induce a delirium. And I've taken care of patients in the hospital who have been admitted for acute encephalopathy as a result of Benadryl. And so, Benadryl is a very low-hanging fruit of, if the patient is taking this, unless it's life or death that they take it for some severe allergic reaction, probably don't use it and use something else instead for allergies or whatever it is that they're taking it for, to minimize that anticholinergic index. But what we know is that more than just Benadryl has anticholinergic action. The gold standard anticholinergic medication is something called atropine. And so what this anticholinergic burden index is somebody took a bunch of different drugs in the lab and did studies on them to see how anticholinergic they are compared to atropine. And they created this index of giving drugs scores of 1, 2, or 3, with 1 being a little bit anticholinergic, 3 being as anticholinergic as atropine, and 2 being somewhere in the middle. And what we found is that drugs that we commonly think of as anticholinergic were, Benadryl, highly anticholinergic. Urinary incontinence meds like oxybutynin or tolterodine, highly anticholinergic because they're operating through very similar pathways as Benadryl. But there were a lot of drugs that we realized through doing this that actually have anticholinergic action that we don't typically think of as anticholinergic. For instance, you'll see down on the bottom here, I have famotidine. That's an H2 blocker used often for heartburn or gastroesophageal reflux disease. And as an H2 blocker, they say it's different than Benadryl, which blocks H1, and you don't get the cognitive side effects that you would from Benadryl because it's not blocking those H1 receptors. But nothing is pristine, and something that blocks H2 is probably going to block H1 to a tiny degree too. And sure enough, it's not a lot. It's in the ACB score of 1, about a 20% as anticholinergic as atropine. But every little bit counts. Furosemide, which is down in the bottom right, that actually amazingly has anticholinergic action too. We see it in the score of 1. And there's some other ones that show up there that are a little unusual too. Digoxin, atenolol. We've got metoprolol, nifedipine, lisinopril is even on there. So if you have heart failure and you have atrial fibrillation, already, just by the drugs you have to be on those for those 2 diseases, you probably have an anticholinergic score of 5. Does that mean we need to stop Lasix on all of our heart failure patients because it may induce anticholinergic action and increase the risk of cognitive impairment? No. But what it means is that if they already have to be on those medications for their heart failure, when they develop urinary incontinence from the furosemide that they're taking, maybe don't start them on oxybutynin or tolterodine or another antimuscarinic agent to try to block urge incontinence. Number one, because it's not going to work, because urge incontinence is different than incontinence from diuretics. And number two, because oxybutynin, or it's like have an anticholinergic score of 3. And that may be the straw that broke the camel's back that tips us over into an anticholinergic delirium. So really what we want to do when we're thinking about medication review is look at how many medications a patient is on that have anticholinergic property and try to reduce that number. Substitute where we can to agents that don't have anticholinergic action. And if we can't, at least be cautious about adding new medications that are going to increase that total anticholinergic score. And if we can focus on these meds, we often are going to be doing our patient a much greater service than just randomly trying to address every issue related to polypharmacy the patient may have. Another thing to think about is supplements. It's important to remember that supplements and herbal remedies contribute to polypharmacy. All over-the-counter medications, including supplements and herbal remedies, count for that raw total number of pills somebody is taking that defines polypharmacy. And polypharmacy itself is defined as taking 4 or more pills in a given day. Supplements are very common. And unfortunately, there's not a lot of benefit for them. One recent study found that 4 out of 5 older adults above the age of 50 use at least one supplement. But the issue with them is that beyond just contributing to polypharmacy, some of them can have side effects and medication interactions. And so especially from the perspective of memory, we need to use caution with these agents. For instance, we've got St. John's wort here, a supplement that's sometimes used for treating dysthymia or even depression in the naturopathic world. The issue with it is that since it's being used to treat those, it's got some serotonergic action. And so if we're taking this and we're also on an antidepressant that boosts serotonin, that may be enough to cause a serotonin syndrome. Significant harm can come from that. So if we aren't thinking about or asking about these supplements, we may wind up getting our patients into trouble with prescribing. Here's an example from a clinic of an approach to deprescribing. So I'd been seeing this patient in clinic who had been coming in for evaluation of memory, had a few medical problems, high cholesterol, asthma, ABPA, and had been residing in an assisted living facility, was receiving medication management assistance there, and was because he was having a lot of difficulty managing his pills by himself. He had also been having significant amnestic symptoms typical of late onset Alzheimer's disease with deficiencies in his IADLs, had recently lost his license after crashing his car in a parking lot and failing the DMV written test. And so this was his medication list, and he'd been asking me, what can I do about this? Is there anything on here I should be thinking about that I shouldn't be taking? And so this is what we wound up doing with this list, is going down the line and finding things that either didn't have any evidence of benefit or potentially had drug-drug interactions to try to curtail the amount of pills that he has to be taking. We stopped many of his supplements that he was taking because there was a lack of evidence of benefit with no evidence of any micronutrient deficiencies on his labs. He had been taking, for instance, vitamin E, as well as ginkgo biloba, both of which are often given for cognitive impairment with the hope that they help. But the problem with them is that both actually increase bleeding risk to roughly the same amount as a baby aspirin a day. He'd also been taking a baby aspirin a day, although the Esprit trial argues that in his case, with his age and his lack of cardiovascular history, there isn't evidence of benefit for taking primary prevention with aspirin, but also an increased bleeding risk. So already he's taking basically 3 aspirins a day with his aspirin, ginkgo, and vitamin E, which could increase his risk of bleeding. And why do we worry about that? Well, some of the risk of bleeding can be cognitive, can be bleeding in the brain. And so these little micro hemorrhages that you can get at a higher risk in patients with Alzheimer's disease can be exacerbated by these agents. So we wouldn't want him taking these because they could potentially cause harm. And when we're worried about cognition, worried about protecting our brain, getting rid of these agents may be the best outcome we can go for. And so this was an example of how his medication list looked at the end of the visit. Much smaller, wound up helping him in terms of management, and helped his facility too in terms of reducing the raw number of pills he had to take, which actually lowers his cost for having medication management from his facility. But I can talk about polypharmacy all day, but we do still have 4 more topics to get through. So appreciate you bearing with me here, and we will move on to physical exercise, part 2 of the Brain Health Plan. And what we've found is that physical exercise is something that's been consistently associated with positive cognitive outcomes in the older adult. Multiple studies have looked at the effects of physical exercise on cognitive function, and found a statistically significant, and in many cases clinically significant, improvement in terms of cognitive outcomes. In particular, these are highlighting a study with a meta-analysis looking at the effects of exercise in patients with dementia, and found multiple studies showing a trend toward improved cognitive test scores on ADAS-COGs and MoCAs in patients who had a robust physical exercise regimen. But the problem becomes, well, what is physical exercise? What should we be advising our patients when they're worried about cognitive health? And my usual discussion with patients is as much as you can tolerate. I usually talk to them about what we're about to talk about, which is the Surgeon General's recommendations on exercise for the older adult. But if we try to have a patient do everything all at once, if they may not have a good history of adherence to exercise, it may just be too overwhelming and they choose not to do it. So at least pushing the goal, setting reasonable goals to achieve, and once they're achieving it, then encouraging more exercise is probably the better way to go about it. But as far as what's actually recommended, one of the biggest is aerobic exercise. And we think that this helps mainly because it's helping reduce that cerebrovascular risk by maintaining good and healthy heart and healthy blood vessels. We're maintaining a good and healthy brain as a result of reducing the risk of vascular stress and strain on the brain. And so what's recommended there is 150 minutes a week of aerobic exercise, moderate to high intensity, such as a brisk walk for 30 minutes, 5 times a week. But as with the older adult, we often find that, they laugh at us when we talk about brisk walking because we have arthritis that develops as we age. And so it becomes hard to briskly walk for 30 minutes, 5 times a week, if we already have some arthritic knees or backs or things like that cause too much pain with doing high strain activities. In which case, I often will recommend instead what's pictured here, water aerobics, a way to kind of get your cardiovascular or physical exercise, but in a way that's low impact on joints. But in addition to aerobic exercise, it's also recommended to add several other modes of exercise to one's regimen, including muscle strengthening and balance training. Muscle strengthening is recommended to be done 2 or more days a week for 20 to 30 minutes a time. It can be something like using weights or exercises like crunches or climbing stairs or some type of resistance training. Again, water aerobics can be a useful method here of kind of doubling up. You get your aerobic exercise, but also with the water resistance, you get some resistance training through that as well. But more importantly than that, I feel like, is balance training. Because as we age, one of the normal physiologic things that happens to us as we age is that proprioception becomes reduced in our feet. Part of this is due to vascular changes and blood flow and circulation issues to the feet that can cause damage to the tiniest neurons there. The other is that we know that as we age, the myelin sheath that surrounds our nerves actually degenerates a little bit as a normal part of aging, which causes the nerve conduction velocities of our nerves to reduce. We think this is why reaction times are slower in older adults. It's also why we affectionately call them senior moments, why patients have harder time recalling information. But eventually it comes to them, is that those are normal things that happen with age. We think because of this slowing of nerve conduction velocity. Both our feet being the most distal points of our body, takes longer for conduction to travel there. So we often find that balance can be affected as a result of that as well. And so why is this important? Well, one of the major risk factors for cognitive impairment is falls. A single fall with head injury can lead to cognitive problems. And so anything that we can do that can help prevent our risk of falling can actually help in terms of creating a healthy brain. The best studied balance training exercises are Tai Chi and yoga. Many of these also include some degree of resistance, some degree of cardiovascular exercise too. So especially in a patient who just doesn't exercise or has a lot of joint issues that prevent them from doing kind of really good rigorous exercise, if at least I can get them doing a Tai Chi or a yoga class one or more times a week, they're already ahead of the game. And so these are some ideas of ways to think about discussing exercise with the older adult and hopefully to empower them to actually do it. Attached to that is also mental exercise. This is, I think, a lot less well studied, but probably a lot more impactful even than physical exercise as far as something that we can focus on to really help the brain. Certain factors in the literature have been associated with a later onset and slower progression of cognitive decline. These include higher formal education levels, later time of retirement, and higher levels of cognitive activity. So usually there I get at least one person listening, pausing and being like, wait, did you just say retirement? There was one study that showed that post-retirement, there's an increased risk of cognitive issues. But the more that we look at it, the more that we realize it's not retirement that's causing an increased incidence of cognitive decline, but rather the post-retirement lifestyle. Because think about what we do when we're working. Doesn't matter what the job is, our brain is constantly being challenged by new situations, things in which we have to problem solve, think through, come up with creative solutions to address. But when we retire, we often aren't challenging our brain to the same level that we were when we were working. A lot of times when I talk to older adults post-retirement, it's what do you do with your day? Well, I spend a lot of time watching TV. Maybe I have some activities that I do with friends or family a few times a week, but most of the time I'm just at home kind of vegetating. And it's probably that, not the retirement itself, that has the higher incidence of cognitive issues, is that if we aren't using our brain, it's not going to function as well. So if we retire, we need to find something that we do that keeps our brain operating at the same level as when we were working. And so that's what mental exercise is really all about. And what counts as it? Really anything that gets the mind thinking and problem solving. There are a lot of commonly used methods in the literature. I've listed some of these here: reminiscence therapy, cognitive stimulation therapy, music therapy, relaxation, snoozelen therapy, creative activities. The problem with a lot of these is that it's hard to study cognition and mental exercise in the literature. So we often choose something kind of narrow that's an easily achievable target to affect outcomes. But unfortunately, anytime something is kind of very narrow, a narrow target, it's probably a narrow target on the brain too, and isn't working that well at improving cognition. So we don't necessarily want to stick with just these to really keep the brain active and engaged. But there's some interesting ideas with them that can help us at least start to think about what counts as mental exercise. The snoozelen room is one that I often get questions about. I mention it here, not because it's something that's actually recommended these days, but more that it's something that highlights some of the issues with mental exercise. Is that a snoozelen room is something like what's depicted here. It's a multi-sensory room that is meant to be engaging on the mind, but also calming on the mind. And it was created initially for patients with autism spectrum disorders. And so there was some literature a while back looking at, can snoozle in rooms help with patients with dementia, reducing agitation or keeping the mind engaged, etc. And initially there was some promise to them, but what we found is that they're hard to actually create and maintain. And then also the evidence hasn't really panned out that they help significantly, probably because it's really more of a calming technique rather than something really active and engaging the mind. But the good thing is people are constantly thinking about new things we could try, such as this, to try to improve mental exercise. Um, but we need to really be critical about the literature when we're thinking about what counts as mental exercise and what we can recommend to our patients. Many times I hear, and I was even taught in medical school, recommend brain games, things that are cognitively stimulating for the brain. But unfortunately, every few years we see something like this. The FTC back in 2016 sued a company called Lumosity for making false advertising claims that their app protected against cognitive decline when there was no evidence to support it. Over and over again, we see that brain games, when we actually study them, don't actually have good cognitive outcomes. The evidence for brain games largely came from this large study called the Active Study Group. And what it found is that when patients did brain games, focused on either memory training, reasoning training, speed of processing training, or a control group, they found that as the person did the task over and over again, they did better at the task than the control group, regardless of their cognitive status. So that's what people thought of, hey, great, this is something that's improving our cognitive abilities. But several studies since have also shown that when we look at cognitive training, there haven't been any significant effects attributable to consistent cognitive training. A Cochrane review, for instance, in 2007 looked at 32 different trials of cognitive training and found that there were no effects that were attributable to that were not due to other things in one's lifestyle. And a systematic review was done by a group in BMC Geriatrics in 2011 that looked at 10 different studies of cognitive training in patients with mild cognitive impairments. And what they found was that the variability in outcomes was wide. The sample sizes that were studied were small. There was lack of standardization. Only a few were randomized control trials. There was just inconsistency in the data and difficulty in interpreting what the data meant. So, to date, we really haven't found a clear benefit other than if you do brain games a lot, you're going to do better at that brain game as a result. But does that translate to a functional improvement? Probably not. I often will tell my patients it's kind of like a rat in a maze. If the rat does the maze over and over again, it's going to learn the maze and do better at the maze. Does that mean that the rat has gained an extra level of intelligence? Philosophers will disagree on that. But it's a realm of philosophy and probably not something that's leading to significant benefit for the patients. More what it's doing is that brain games are learned pattern behaviors over and over again. If we do a pattern, we're going to do better at it, but we're not going to think better as a result because it's just too simplistic of a task. So generally, I don't recommend brain games unless the patients like them and they aren't spending a lot of money on them. But really what we want to focus on is something bigger. A nice example of that comes from this documentary called Alive Inside. And so what this was a documentary of a neurologist looking at patients with advanced dementia, many of whom had lost language ability. And there was one patient that he had that in the past had done a lot with music. And so the neurologist had found some music that the person had made and played the music to him. And when it came on, he's like, I remember when I made this, and was able to engage in conversation from a patient that normally can't even reply to a simple yes/no question. And so the thought was, well, what's happening there? And what we've realized is that music memory gets stored in a different part of the brain than regular memory. Music memory is stored in the deep parietal lobe, whereas regular memory is stored in the hippocampus. And so this guy had spent a lifetime exercising the music memory center of his brain, playing music, performing music, recording music, listening to music, etc. And by doing that, what it had done is it created neuroplasticity. That music memory center had started connecting to other surrounding neurons, such that later in life, when his music memory center was activated, it allowed it to serve as a backdoor into regular memory and access things that were otherwise blocked off by neurodegeneration. So, does this mean that we should be telling all of our patients to go out and learn music? No. But what it means is that when we're thinking about mental exercise, rather than having the patients do something simple like play a brain game, we should instead be focusing on doing something that forces the brain to use multiple processes outside of the memory center. Because the more that we use our brain and the more that we use the parts of our brain that are intact, that are not degenerating from a neurodegenerative process, the better our brain as a whole is likely going to function. And it's never too late to exercise these parts of our brain. And so doing that helps kind of build redundancy. And so what I often will say with that is, one of the best things that you can do in terms of mental exercise is get a hobby. And it sounds tongue in cheek, it sounds a bit flip, but it's true. Anything that falls into the category of a hobby is cognitively complicated enough that it should be making multiple parts of our brain interact with each other, forcing our brain to work through problems and come up with solutions. And so anything that's a hobby is going to be as cognitively complex as, say, learning an instrument, in terms of helping protect and preserve the brain. So, exploring with patients what their interests are and then tailoring mental exercise to their interests, to things that they can do, that they are interested in, that they like, that are outside of rote memory, is probably going to be the best way to kind of do our patients a service. Next up, another key component is social engagement. And the pandemic really helped show us just how important socialization is in terms of protecting cognitive health. Many articles exist looking at the effects of COVID on cognitive health. And what we found is that there was a lot of issues related to cognition and social isolation. There was increased incidence in behavioral disturbance in those with cognitive symptoms, as well as increased onset of concerns about cognitive health as a result of a pandemic. Prior to the pandemic, my wait time to get an appointment with me in a memory clinic to be seen to evaluate your memory was next week. Now, post-pandemic, I'm looking at a 6-month wait list. And it's because what we found is that the social isolation really started to unmask issues that may not have presented themselves for several years because family wasn't there to help accommodate for those issues. One good example is had a patient that came in, and the issue that led them to seek cognitive health was that their optometrist had suggested it. And it's a far stretch to wonder how an optometrist evaluation leads to you should get some concern about your memory. And what had happened is that he had misplaced his glasses, and when he misplaced them, he couldn't find them, so he went back in to get a new pair. In a period of a month after he'd replaced them 3 times, suddenly it became evident that this guy's having some issues with misplacing objects. And part of it is that, previously family had been around to help. And how often do we put our glasses down and forget about it? But somebody's like, hey, you forgot your glasses. But if nobody's around to remind us of that, maybe we're in getting a replacement pair a few too many times, and suddenly we start to see the problem that's there. Doesn't mean that problem wasn't there to begin with, but what we found is that having this social network, having people that are there to help us with identifying areas that we're weak at, can help kind of serve as an external brain and allow us to function better as a result. May not do anything about the neurodegeneration, but the more functional we are, the better off our cognition is. And so the pandemic really showed us just how important socialization is. So what can be done for that? There are a lot of things that are out there structured to try to help, but one of the biggest is group activities. The more that we can do things with other people, the better off we're going to be. Multi-generational households is another key. If that's just not possible, thinking about things like adult daycare services can also help. And there are resources in the community to help look into this, especially in San Diego. We've got the local chapter of the Alzheimer's Association, Southern Caregiver Resource Center, community centers, Alzheimer's San Diego, and more that can help with that. But the key is to look for things that we can do with others. And so, especially with that mental exercise piece, I often will pair it and say, don't just read a book in a book club, because then you're with other people having to discuss what you read, adding an extra layer of understanding to that, and just socializing with people who could then start to look out for us and be aware if we're having issues that can be helped. So again, as to what to practically advise in clinic, if nothing else, exercise and get a hobby. I will tell people that time and time again, is that that's one of the best things that we could do to really protect our brain. And if we can do that, we are far and above other patients in our and our peers in terms of doing what we can to protect our brain. And if we can do those hobbies with other people, even better. So to summarize the brain health plan, really what we're doing is we're establishing multiple different things to try to do everything we can to address cognition and help cognition, prescribing an exercise regimen, doing a thorough review of medication, including supplements, and deprescribing wherever possible, especially anticholinergic meds, encouraging mental activity tailored to the patient's capabilities and interests, educating on the importance of socialization, providing resources for community opportunities in this regard where we can, as well as ensuring a physical health review and addressing and optimizing physical health issues. And this can be done through avenues such as the annual wellness visit, which also includes screening for depression, vision, and hearing. So the good thing is there are ways in which we can do this in clinic in a practical way that can help us, the annual wellness visit being one of the biggest. But having this discussion with our patients is going to do them much more good than just saying, here's some donepezil, see you back in 3 months. I'm a part of a group called the Alzheimer's Project of San Diego, and we have this flyer that you could access on our website for free, Healthy Body, Healthy Brain, that tries to go into some of these details for patients and for the patients that are in front of us. And so you can access this through our website, championsforhealth.org/Alzheimer's. And it's something that you could hang up in offices, etc., as one way to kind of get this information to patients in a different way. And with that, we will end it. Thank you very much.